I want to talk about coronary perforations, and I want to describe in detail how to deploy coils. There are two major categories of coronary perforation. You have the small vessel perforation, which could be a distal main vessel or a distal side branch wire perforation. This is usually due to a wire perforation, and this leads to less immediate hemodynamic effect if recognized and treated early on. Tamponade and hypotension may occur usually only if it is not quickly recognized. Large vessel perforation, on the other hand, is often related to balloon, stent, atherectomy, or rotablator perforation. It causes major hemodynamic compromise, and it often requires pericardiocentesis. In terms of severity, there are three types of perforations that you need to know, the so-called Ellis classification. You have type 1, where you have a small extravascular stable stain. You don't see contrast coming in or going out of it. Type 2 is that you have active blush. Basically, you have active contrast filling of a localized small area. Contrast comes in, but it doesn't go out of it. So there is contrast movement, but contrast does not clear. And it's typically a small area, and you typically don't see the size of the hole. And type 3, you have active contrast filling of a much larger area. You can even see the size of the hole of the perforation. And contrast doesn't just fill that area, it clears out of this area quickly. This is what we call a free-flowing stream. Now, type 3 can be in the pericardium, which is the most dangerous perforation. It leads to tamponade immediately. Or it could be type 3 into a cavity, such as the ventricle, and that will lead to a coronary cameral fistula with much less immediate hemodynamic effects. So type 1 and type 2 typically occur with a small vessel perforation, wire-related perforation, and they lead to less immediate hemodynamic effects, whereas type 3, the free-flowing, contrast, filling, and clearing of a large area occur with large vessel perforation, balloon or stent or rota perforation, and typically requires pericardiocentesis. In terms of management, there are generally two big steps for all perforations. One is immediate prolonged balloon inflation for 5 to 10 minutes. This is for both small and large vessel perforations. And a second big step that is simultaneous to number one is pericardiocentesis and fluid pressors, but this one only if there is hypotension, which is typically the case in large vessel perforation, where you almost always need pericardiocentesis and fluid pressors. It is less often needed in wire perforation, small vessel perforation, but it would be needed in large wire perforations, or if that wire perforation is not recognized early on. So when you need those two steps simultaneously, you typically need to call a second operator to help you. He would do the pericardiocentesis while you're focusing on the coronary, doing the balloon inflation and eventually potentially deploying a cover stent in large vessel perforation. Now, specifically, small vessel perforation, here are the steps. One, you do prolonged balloon inflation at low pressure proximal to the perforation site for 5 to 10 minutes. In side branch distal small vessel perforation, you can inflate the balloon in the side branch, or you can inflate the balloon in the main branch across the ostium of that side branch. If that perforation does not seal with prolonged balloon inflation, and it frequently does in small vessel perforation, it frequently seals with prolonged balloon inflation. But if it does not seal, then advance a microcatheter, 014 or 018 inch, preferably a fine cross microcatheter, distally into the vessel of interest, close to the perforation, and then do typically and most efficiently do coil embolization. You may try fat or clot embolization, and you may try easily before any of that negative suction on a 20 milliliter syringe attached to that microcatheter. This may collapse the small vessel and lead to its clotting, occasionally. Occasionally, for distal side branch perforation, you may place a cover stent across the ostium of the side branch, but that's not the best option. The best option is coil embolization. For large vessel perforation, you immediately do prolonged balloon inflation with a balloon 1-to-1 size to the vessel, low pressure at the perforation site, and simultaneously to that, overwhelmingly, most often, you need to do pericardiocentesis and fluid pressors. In those emergencies, pericardiocentesis is done if hypotension, even without echo confirmation. You can do the pericardiocentesis blindly or with echo guidance, or you can use a fluoro guidance if needed. So typically you do those two steps simultaneously, pericardiocentesis and prolonged balloon inflation. Then you do the third step, which you would overwhelmingly need in large vessel perforation, which is advance a covered stent while a balloon is still inflated. And I will detail that a little later. As a general rule, do not reverse anticoagulation until all coronary equipment is removed at the end of the case. Otherwise, you will end up with catastrophic thrombotic complications in your coronary artery. After removing your coronary equipment and your guide, you may consider partial heparin reversal. You may use 0.5 to 1 milligram protamine for every 100 units of heparin. Typically, you would use 20 to 30 milligram and certainly no more than 50 milligrams. Now, specifically for small vessel perforation, I mentioned fat. I will explain fat embolization briefly. The way you do it, you make a small cut in the groin and you remove a small piece of fat from the groin using a hemostat. You put that small piece in a bowl and you cut it into small 1 to 2 millimeter pieces with a scalpel. You dip those small pieces in contrast to make them radiographically visible. Then you put those small pieces in the microcatheter that is inside that small branch. You push those small fat pieces in the microcatheter with a needle introducer, typically while holding the microcatheter a little bit upside down, just because fat floats up in water. So you put it a little upside down, you put those small fat particles at the hub, and then you push them with a needle introducer inside the microcatheter. Then you flush them with 2 millimeter saline syringe into the microcatheter all the way into the coronaries, and having dipped them in the contrast helps confirm that you have advanced them all the way to your perforated branch. You may alternatively push them with a coronary guide wire like pushable coils, but typically it's better to flush them with 2 milliliter syringe. You may also use clot instead of fat. You may use a clot that has formed anywhere in your field and dip that clot in contrast and flush it through the microcatheter with a small syringe. And this is an image of fat particles that you harvest from the groin and that you would cut into small 1 millimeter pieces. And then you would push them into a microcatheter that is held a little bit upside down. But the most efficacious intervention for small vessel perforation that doesn't seal with prolonged balloon inflation is coils. And coils can be confusing because there are many brands, many shapes, but what you need to remember is to pick coils that are 0.014 inch or 0.018 inch compatible, not the 0.035 inch coils, which tend to be large and which are used for peripheral vascular interventions. And you have many sizes, but the typical size we use, and remember that, is 2 millimeter diameter by 2 or 4 centimeter length. The diameter, this one here, the 2 millimeter, should be larger than the diameter of the vessel of interest. So it's typically 2 to 2.5 millimeter. and the length 2 to 4 centimeters. And coils come in pushable and detachable forms. And I will explain both. Detachable are the best, but you need to be able to use both. First, you have to advance a microcatheter, 0.014 or 0.018 inch microcatheter into the perforated branch or vessel, a bit proximal to the leak. Then through that microcatheter, you will eventually advance your coils. Now, while you're delivering the microcatheter and the coils, you may have another wire and balloon inflated nearby proximally to control the bleeding while you're delivering the microcatheter and the coils. This is not absolutely necessary in small vessel perforation, just because the bleeding and the leak may be slow enough to allow you to do all those maneuvers without having a balloon inflated to control the bleed. And you need to know sizing. If you choose to have a blocking balloon inflated while you're doing your maneuvers, you need to know that the 6 French guide can fit a balloon next to a microcatheter only if you are using an 0.14-inch microcatheter and not any microcatheter, only fine cross or caravel or over-the-wire coronary balloon. So it's not going to fit Corsair along with a blocking balloon. Corsair, Mamba, they will require 7 to 8 French to fit simultaneous balloon and microcatheter. And for that reason, as a general rule, if you want to remember one catheter for all coil maneuvering, remember fine cross. It's the catheter with the lower profile among all microcatheters, so it's the most forgiving in terms of fitting microcatheter with balloon next to it. And it's also the one that accommodates the most coils. It actually accommodates more coils than Corsair and most over-the-wire balloons. It can even accommodate some 0.18-inch coils. So remember, small vessel perforation, fine cross is your best catheter for coil embolization. I will explain a little bit the pushable coils, then I will explain the detachable coils. A pushable coil, for illustration, I will use Azure coils by Terumo. Azure comes in detachable or pushable. It is designed to go through 0.18-inch catheter, for example, Prograde catheter, Renegade catheter, or any peripheral 0.18-inch microcatheter that your vascular or radiology colleagues use in peripheral interventions, such as CXI or Quick Cross 0.18-inch catheter. Those 0.18-inch coils, Azure, may possibly go through the 0.14-inch fine cross based on a Sky online publication. I'm not certain of that, though. The general size for coronaries is 2 millimeter by 2 centimeter or 2 millimeter by 4 centimeter. Same for pushable or detachable. And you may need multiple coils to stop the bleed. Keep also in mind that those coils are coated with a hydrophilic coating that further expands once it's in the body for a few minutes. It will further swell and expand and stop the bleed. So you may not stop the bleeding immediately as you have the coils in, but the bleeding may stop several minutes once that hydrogel expands. And I will explain now how to advance those pushable coils, and I will use Azure Terumo for illustration. Those are the two typical components of a pushable coils. You have the sheath, which has coils inside it. It's a white plastic sheath with those black coils inside it. And you have a stylet for the initial push of the coil inside the microcatheter. And you can see here in magnified form the sheath and the coils inside it. So you flush that sheath, you remove the cath from the back of the sheath, you flush it, then you insert that plastic sheath into the hub of your fine cross that's already into the perforated branch. You insert it a couple of centimeters into that microcatheter. Then you use a stylet to push the coils from that introducer white sheath into your microcatheter. Then once those coils, those black ones here, are pushed into the microcatheter, you remove the introducer sheath and the stylet. And now you just push those coils that are into your fine cross microcatheter. You push them using a standard workhorse 0.14-inch coronary guide wire. Use the soft tip of that coronary wire to push the coils, not the risky back end. So you push them with your coronary guide wire, and you see them on the X-ray exiting the microcatheter. Now, once those coils exit the microcatheter, that's it. It's irreversible. They are deployed. You cannot take them out. You cannot change their position. And that's the downside of those pushable coils. You need to be certain of a proper position and a proper sizing. And this is where detachable coils are advantageous. You can adjust the position of the coils as well as the microcatheter before you deploy them. And the best detachable coils are the ones that will fit into 0.14-inch catheter, such as fine cross catheter. And to my knowledge, those are the ones I'm familiar with, and those are the ones that my lab has. They are the Axiom neurovascular Medtronic coils, or also the Concerto peripheral vascular Medtronic coils. Those fit into 0.14-inch catheter, typically fine cross or Corsair, or some over-the-wire balloons, not all over-the-wire balloons. Probably they fit into the Medtronic over-the-wire balloons, but may not fit into other over-the-wire balloons. So those are the better ones because they fit into 0.14-inch catheters. Other companies have detachable coils such as Terumo Azure coils, like the Terumo Azure pushable coils, but those require 0.18-inch catheters. And these are the 0.14-inch Medtronic detachable coils. You have the Concerto coils, and you have the Axiom neurovascular coils. They are helical in morphology. And those detachable coils have two components, like microvascular plugs. You have a wire attached to the coils, and you have a plastic introducer sheath. This introducer sheath allows you to push the coil through the microcatheter that is inside the coronaries, and I will show more of that. So this is how those coils come out. You have wire at the back that is attached to the coils, and the coils are inside a white plastic introducer. So you have the coils attached to a wire that comes out at the back, and you have the plastic introducer. And the coils come out of the box already pulled into the plastic introducer. And here you may see the plastic introducer, and inside it you see here the coils, and those coils are attached all the way to a wire that goes all the way out. The introducer white sheath finishes somewhere here, whereas the wire is much longer at the back. And this is how you push the back wire through the introducer sheath. And you can see as you push the back wire, the coils will come out of the sheath. Now, how to exactly deploy those coils into the coronary? You have that microcatheter fine cross into the perforated branch. You bring that white introducer sheath and you insert it into the microcatheter, as you will see here. You insert it into the microcatheter. That after you insert it for a couple of centimeters, you push the back wire through the introducer sheath. You push that back wire, which will push the coils into your fine cross. And after you've pushed that wire for 10-20 centimeters, you just take out your introducer catheter, which only value was to allow you to load the coils inside the fine cross, as it was with our pushable coils. So once those coils are inside the fine cross, few centimeters inside it, you just take out that introducer sheath. Now you keep pushing those coils through the fine cross into the perforated branch. And this is how we're pushing the wire all the way through the fine cross into the perforated branch. Now the wire is attached to those coils. You can move it in and out. You can retrieve them in and out if you don't like the position. Once you like the position in the coronaries, you connect the back end of the coil wire to the wand, and that wand will allow the detachment of the coils. You just push the wire into the wand, no clicking. Then after you put the back end of the wire into the wand, you pull backward on the black button, and the coils will get detached from the wire. You pull backward here on the black button, and the coils will get detached. Now, before you detach, you may wait a few minutes and see if that coil is slowing and stopping the bleed. If not, you may choose to not deploy the coil. Ensure you are in the proper sub-branch that is bleeding. Consider deploying the coil more proximally, so pull your microcatheter and the coil more proximally, or maybe pick a larger coil or deploy the current coil and add another one. Keeping in mind that full expansion of the coils take a few minutes up to 20 minutes as the hydrophilic material expands inside the body. And the same technique we use for detachable coils may actually be used for detachable microvascular plugs, which we don't use in coronary perforation, but we may use them for coronary fistula. You have a wire attached to a microvascular plug, and you have an introducer system that allows you to push those plug into a microcatheter that is inside the coronary. The microcatheter needed for a microvascular plug is an 0.35-inch system. This is an illustration of a case. This patient had a severe proximal LAD stenosis significant by IFR of 0.82. She underwent PCI of that proximal LAD while a wire was protecting a small diagonal. Unfortunately, the wire has migrated into a small sub-branch of the diagonal, and there is a distal diagonal perforation. We tried prolonged balloon inflation with no success. So we advanced a microcatheter into the branch. We used Corsair here, while a wire is still in the LAD. We did not have a blocking balloon inflated in this case. So after advancing the Corsair microcatheter, we tried aspiration with a 20 milliliter syringe, no success. We tried to advance fat that we retrieved from the groin, also no success. So we decided to deploy coils. Keep in mind, when you inject fat or coils, you have to make sure the catheter is in the proper sub-branch. Inject contrast through that microcatheter and see the leak from that branch. So here we're injecting and we're seeing we're in a proper position because we can see leak from that branch. So we advanced a detachable axiom neurovascular coil, the one that goes through 0.014-inch. We advanced them through Corsair, but this did not stop the bleeding. We injected and we can see that there is still a bleeding, probably because those coils were in another sub-branch. So what we did here, we pulled the coil more proximally, and we saw if this controlled the bleeding, and it did not control the bleeding. So what we ended up doing is pulling the whole microcatheter more proximally and deploying the coils yet even more proximally to stop the bleeding. And we only needed here a 2.5 by 4 centimeter one coil. And you can see here the result. There is no longer any bleeding. I will move on to describe large vessel perforation. Again, the two immediate steps are prolonged balloon inflation, 1-to-1 size, low pressure at the perforation site for 5 to 10 minutes. And simultaneously, if there is hemodynamic compromise, which is the case in the overwhelming majority of large vessel perforation, you will do pericardiocentesis and fluids pressors. And pericardiocentesis, when there is hemodynamic collapse, may be done blindly without any echo guidance. You can assume the patient has a large effusion and stick blindly the subcostal area. You may use fluoroscopic landmark, and if you have the time, you may use echo guidance, but be ready to do even a blind pericardiocentesis. As I said, it's good to have a second operator readily available to do the pericardiocentesis while you're focusing on the coronary maneuvers. Now, aside from those two simultaneous steps, you have to get ready to advance a cover stent. You overwhelmingly, in those cases, need a cover stent. It's rare for prolonged balloon inflation to see the bleeding in large vessel perforation. So for that second step, advancing a cover stent, you're typically doing while having simultaneously a balloon inflated in the coronary. You don't swap the balloon for the cover stent. You keep the balloon inflated, you advance another wire in the coronary, and you advance your cover stent. This is done in order to control the bleeding while you're advancing your cover stent. If you try to swap your balloon for a cover stent, the patient may have large amount of bleeding during this swapping 1 or 2 minute process. So it's best to keep the balloon inflated while you're advancing your cover stent. And I will explain more in detail how to do that. But first, there are two types of covered stent. You have the graft master, the old-fashioned one, which consists of two bare metal stent, the gray ones with PTFE covered material, the blue one that is sandwiched in between the two stent layers. Then you have the modern PK papyrus stent, which consists of one covered membrane, the green one, and inside it you have only one bare metal stent, thin bare metal stent layer, as you can see here. So PK papyrus has much lower profile, which leads to easier delivery and allows it to go through a smaller guide. For sizes 2.5 to 4 millimeters, PK papyrus can fit into a 5 French guide, and for larger sizes, you need a 6 French guide, whereas a graft master needs 6 French guide for 2.5 to 4 millimeters and 7 French guide for 4.5 and 4.8 millimeter stents. Another advantage of PK papyrus cover stent is not only it fits easily through a 6 French guide, you can even fit next to it a balloon simultaneously inside a 7 French guide, or even inside a 6 French guide, as long as both the balloon and the PK papyrus are probably less than 3.5 millimeters. Whereas with a graft master, in order to fit a simultaneous graft master stent and balloon, you need an 8 French guide. And here I will detail more how to advance the cover stent while you have simultaneously a balloon. So let's take the ideal scenario of delivering a PK papyrus stent, and let's say we have a 7 French guide. While a balloon is inflated across the perforated area and controlling the bleed, you briefly and intermittently deflate that balloon in order to double wire, then in order to later advance the PK papyrus cover stent. This is what we call the block and deliver technique. You're delivering your PK papyrus while you have a balloon blocking the bleed in the interim. Now, this may be done with PK papyrus in a 7 French system for all sizes of PK papyrus. It may even be done in a 6 French guide if you're using, like I said, a smaller PK papyrus and smaller balloon, probably less than 3 to 3.5 millimeter for both balloon and papyrus. However, if you're using 6 French guide and you need to deliver a larger PK papyrus stent, or if you want to deliver a graft master, and in order to keep your balloon inflated while delivering your cover stent, you need to do in those cases what we call a ping-pong guide. You need to do a second arterial access and a second guide engagement. So in those cases, you disengage the first guide that is holding the balloon, then you engage the second guide, you wire, and you deliver your PK papyrus, all while the first guide is disengaged. Then you deploy your PK papyrus. And keep in mind, whether with a ping-pong guide or with a single guide strategy, after you deliver the papyrus and before you deploy it, evidently remove the wire and balloon. You don't want to, of course, jail the wire and balloon behind the PK papyrus. So you remove those just before you deploy your covered stent. So again, this is a summary of large vessel perforation, 2 simultaneous steps, pericardiocentesis and prolonged balloon inflation. Then the second step is to double wire and advance a cover stent while a balloon is still inflated. This can be done via the same guide if you have 7 French guide and piquet papyrus, or if you have a 6 French guide and you're using a smaller piquet papyrus and smaller blocking balloon, or this may be done via a ping-pong 2 guide engagement strategy. One final idea here, when you do pericardiocentesis, the blood that you aspirate, you may choose to auto-transfuse it back into a femoral vein sheath. The blood that's in the pericardium is unlikely to clot as the patient is still anticoagulated. You may also call the cardiac surgery OR and bring a cell saver system that filters the clot before you transfuse that blood back into the femoral vein sheath.